Thank you. I also would like to thank Dr. Vijay Bada and his team for the kind invitation, and my sincere apologies for not being present there physically. So, for the next 10 minutes, I'll be speaking on thoracic duct management in esophagectomy. The overview of my lecture would be give a brief on the anatomy of thoracic duct, the oncological outcomes associated with thoracic duct excision, the strategies for the preservation of thoracic duct, and briefly on the Kylie management. So the anatomy of the thoracic duct, as we can see here, the thoracic duct is marked with a yellow arrow, and it is in the infraesophagus region. It is located between the aorta, descending thoracic aorta, and the esophagus vein. And as we go to the supra esophagus part, it is more towards the left and is away from our dissection field. I'll also show a brief clip of that. And as you can see here, now this is thoracic duct, the glistening tubular structure. So this is without ICG. I'm just initially showing the how thoracic duct looks, and you can see the aorta coming to the view, and the bluish structure is esophagus vein. So this is a typical location, and also you can see the fat associated with the thoracic duct, and that's where the thoracic duct lymph nodes are present. And as we come close to the esophagus, you can see here the thoracic duct, which is on the right side, is now moving towards the left. So this is the place, usually the thoracic duct moves from the right to left. And in a favorable anatomy, you can actually visualize the thoracic duct, the full length, without use of any other agents to enhance visibility. But this is a standard anatomy. Also, we need to recognize that there's a wide variation in the anatomy of the thoracic duct, with respect to the course and also with respect to the number of ducts. Like sometimes you can have the prominent both right and left ducts. So there are multiple variations, and frankly speaking, it is impossible to remember, and also it's impossible to diagnose preoperatively. So what is the basis for thoracic duct excision in esophagectomy? At least what is the basis why that was done routinely? If you see the thoracic duct and its relation to esophagus, there are some direct lymphatic connections between the esophagus and the thoracic duct, and also indirectly through the paraesophageal and the subcarinal nodes. So it has been postulated that thoracic duct excision could improve the oncological outcomes, and that's the basis for routine excision in at least in the various Japanese series which were published earlier. This show a short clip of the direct lymphatic communications. You can see this is the thoracic duct, and you can see these are the direct lymphatic communications. You can see we are pointing with the scissors. So you will have this type of direct lymphatic communications between the esophagus and the thoracic duct. And that is the basis for doing the excision, which we do in some cases. I just show a clip of, especially when you are doing a three-field lymphadenectomy, that's more for prophylaxis of Kylie, and also in some cases when there is a direct involvement of the thoracic duct by the tumor, and where, as you can see here, it is clipped both proximally and distally. So with respect to the oncological outcomes, these are the major series. And as you can make out, the incidence ranges between 8 to 11% of the thoracic duct lymph node metastasis. And in most of the series, the number of dissected lymph nodes is more whenever thoracic duct is routinely resected. And except in one series, the post-op morbidity, the pulmonary morbidity, pneumonia were slightly on the higher side. But at least I'll take you through the specific morbidity related to the thoracic duct excision. And with respect to the survival, except for one of the studies where there is a significantly higher survival in the thoracic resection group, in most other studies, there's no difference in the overall survival between resection and preservation.